tissue, but I want to make sure I get through everything, so I'm not going to let these videos run in full. You can see how thin that tissue is. It's even clefting a little bit at the surface. We use the guided surgery. And you can see the bone quality looks good. You can see how thin the tissue is. And we'll get a little connective tissue graft. We'll suture that to the flap. And we'll close this, let it heal, and then just come back, change to a taller healing cap, and I think a fairly predictable approach for how to manage this aesthetic problem. Well, here's a site with really 100% bone loss, large defect beyond the apex. If I was treating this in the year 2000, I'd be thinking of some type of preservation, I might go back and do a block graft or a large DVR. But I'm able to transition this to flapless approach. This was one of the first cases I did with PVGF in the beginning of 2006. And it was after this case that I switched to using the medical adhesive. And you see here, I just used a small suture to hold the surface. I'm going to let the socket preservation heal. I'll then come back and do a frenectomy. And then I'll do my surgery with the implant and connective tissue graft. Here it is 8-year results, and here it is at 15-year results. And she comes back every couple of years for a follow-up. Craig Mish showed similar flapless healing with BMP2. He's one of the best surgeons I know, but you take a tooth like this sentinel, if you can transform it from the initial CT scan to the post-op scan without doing surgery, what a service for the patient. Well, what do you do here? Come on, right? There's no reason even to graft this site. Just let it heal and deal with it later. Well, if I do that, I'm going to lose the papilla. So it's the same message to the patient. I'm going to graft it. I want to preserve height. I need a lateral GBR. Then we'll do that. Here's the CT scan, better view. Here it is at the time of extraction. Here it is just 10 days later. At 10 days later, you already know this is going to be successful. Again, I'm very strict about implant sites, surgery, and friend of mine that are pulling into the area. So, a friend of mine like this, universally, I'm going to take care of before going back to do the implant surgery. Sometimes I'll do it at the same time as the extraction. And in this case, it looks like I didn't. And then I went back, and this had flap surgery. You can barely see this little edge here where the incision was made, the vertical. And I did a connective tissue graft to the flap, had a small healing cap, went back and uncovered this. We did a provisional this just a couple weeks ago. You can see the nice bone healing and tissue healing. So able to transform the problem without doing major surgical intervention. This patient presents concerned with the aesthetics. She doesn't even know she has bone loss or periodontal disease. And we do a comprehensive exam and we find that she has some other period problems. Her upper right bicuspid is at risk of being lost with 8-9 millimeter pocketing as well as the central. And here I'm going to do laser periodontal surgical treatment. This was published 14 years ago now. So the primary treatment for periodontal disease in my practice is laser-assisted new attachment procedure. No bone grafting. And we're able to document here in a human all of this regeneration of this molar. New bone, ODL, and cementum without any bone material, just laying out surgery. And that's what we did for this patient. With pre-op, post-op charting, you can see all the red deep pockets are gone. You can see the bone fill at 12 months on this bicuspid. Everyone is looking to do an implant here, but I don't think anyone in the room is looking to take this tooth out now. At first, you thought it was going to be an implant in the central, but you can see nice bone fill there, and we're able to solve her problem. Here's her aesthetic. She's thrilled. Well, we can't save every tooth. This patient presented, he was sick. Advanced diabetes, he's almost blind, but you know the patients that you see that you know are unwell, they have like a white-gray complexion to their skin. His diabetes, his A1C was over 9, and he was extremely unhealthy when we met him. I didn't think I was going to make him healthy completely by treating his dental problem. It wasn't until about 4 months later at his post-op when I noticed the complexion difference in his skin. And he said, my endocrinologist is amazing. My diabetes is completely controlled now that we got rid of the dental infection. And he's doing great. But you know, the disease level here, we're not gonna be saving any teeth. We're gonna be doing it all in four with stacked guides. We saw about stacked guides yesterday. And there are just two things I wanna pick up here on the stacked guide. I have three actually. One is, if you've ever tried doing a guide just on the buccal surface, I would love all the researchers here, all the students, I got a great project. You can do it in 3 months. All you gotta do is print models, print guides, and test the variability of guides that are just on the buccal surface with guides that go just over the bridge versus guides that go around the palate. I want to see a test on all three. So Jermaine, can you do that for me?